Today we will be talking about value-based care. This presentation will be presented by physical therapist students from Springfield College and physical therapist assistant students from Springfield Technical Community College.
The objectives of this presentation are to define value-based care and the health and wellness roles of PTs and PTAs, explain the components of access, cost, and quality of the value-based care payment system, understand coding reform and how it impacts payment reform for rehabilitation services, define quality measures and how they are implemented in performance evaluation through MIPS and APM, and to describe how outcome measures are utilized and how they align with performance evaluation.
Some questions to consider as we go through this presentation. What is values-based care? What are the health and wellness roles of physical therapist and physical therapist assistants? How are quality measures used in healthcare? How is performance evaluation measured as part of the values-based care system? Is best practice in alignment with quantity or quality? A payment system is any system used to facilitate financial transactions in exchange for goods and services. In the medical field, this is how providers are reimbursed for the treatments or services provided. Traditionally, reimbursement has been a fee-for-service model. That is to say that providers were reimbursed a specific amount of money for each specific treatment provided. More recently, there has been a shift to payment methods based on the quality of care rather than the quantity. This allows for a system which is more closely related to patient outcomes. This is called values-based care.
Someone's access to physical therapy, the cost of a physical therapy visit, and the quality of care received during a physical therapy visit are all part of value-based care. When it comes to access, there is direct access to physical therapy in all 50 states in the United States. However, insurance companies vary in what they are willing to cover or pay for, which affects where some people can go. The cost of a physical therapy visit depends on institutional fee schedules, contractual relationships, and payment methodologies. The APTA supports charging reasonable fees for services, but patients' welfare should be prioritized over financial gains. Lastly, in terms of quality, physical therapy services should improve, maintain, or slow the decline of current level of function, as well as prevent, slow the progression of, or eliminate impairments of body functions and structures, activity limitations, or participation restrictions. Collaboration amongst team members is the best way to ensure high-quality care.
One of the concerns during this transition is the inclusion of a differential when a PTA provides services in whole or in part. This comes into play when 10% or more of the services are provided by a PTA. Concerns are surrounding what specific duties will fall under this 10%. How will these carry over if a PTA is leading a group therapy session? Additionally, there are concerns as to whether this differential can impact access to physical therapy. Given that some facilities are run by one or two supervising physical therapists with several physical therapist assistants working underneath them, there is potential for this differential to create a barrier in access to care.
The health and wellness roles of PTs and PTAs is to provide value-based care with a goal of improving overall health and the occurrence of preventable diseases in their patients and society. PT and PTAs may achieve this by advocating for scientific, educational, regulatory, and legislative activities that promote regular physical activity and exercise to enhance health and prevent disease. Our roles may include education, direct intervention, research, advocacy, and collaborative consultation. Collaborative consultation often requires relationships with other health service and community organizations to achieve the goal of the profession. These health and wellness roles are essential to the profession's vision of transforming society by optimizing movement to improve the human experience.
The coding reform system is a new payment reform for rehabilitation services. This is done through current procedural terminology, or CPT, which offers a universal code for all the medical services that a provider provides to a patient. As for physical therapy, we used to have one code for evaluation and one code for evaluations. However, as of January 1st, 2011, these codes were revised by CMS and reintroduced as 3 new codes for evaluations and 1 for re-evaluations. This was done because, in theory, it's supposed to help physical therapists to better describe the complexity of the patient's clinical presentations and how it affects their outcome. It also offers therapists to spend more time with their clients based on their complexity of the case. Higher the complexity of the case, the more time spent face-to-face with the client.
Quality measure resources are tools that are used in assessing outcomes and ensuring goals are being met for the patient. The NQF, or the National Quality Forum, is a major organization responsible in improving healthcare in the United States. Quality is varied by social, economic, and geographic boundaries, and to eliminate differences in quality, there needs to be a standardized system for performance measurement and reporting. The NQF directly works on evaluating standardized performance measures to ensure that they are being applied in practice by providers. Some of the tools that the NQF evaluates are measures of structure of care provided to patients, process of how care is provided, outcome measures of care, and patient perceptions of care. Other organizations looking to improve standardized health care is the Centers for Medicare and Medicaid Services, or the CMS. The CMS is implementing Meaningful Measures Framework. The Meaningful Measures is a framework of topics and issues that are vital to providing quality care and better outcomes for patients. This framework streamlines care by taking measures that are important to each individual patient needs. Overall, this is meant to reduce burden on providers and reduce costs to both providers and patients while also providing quality care. The CMS is also implementing Patients Over Paperwork, which is a process to reduce burdensome regulations that slow down and reduce care to the patient by removing obstacles that prevent providers from spending more time with patients. So how are the quality measures being used? They are being used in public reporting, where hospitals and other healthcare agencies are evaluated and then required to report evaluation grades for the public to see. This puts the power in patients' hands to decide where they want to seek care. Pay for performance is the future of reimbursement for healthcare, meaning the better outcome measures are achieved, the more reimbursement facilities receive. This means hospitals and other facilities have to work to meet these goals in order to get paid. Lastly, internal quality improvements are used by facilities as a way to self-evaluate and make changes based off performance. This requires facilities to be constantly self-regulating and adapting with treatment changes in order to provide quality care to their patients.
Now shifting to the quality payment programs of value-based care. Essentially, there are two parts to this program. The first part is MIPS, which is the Merit-Based Incentive Program. The second part is Advanced Alternative Payment Models, which I will get into more detail about in the next slide. These programs are required to have specific quality measures for a practice to qualify. Each one of these has very specific components. Let's first start with the MIPS. In this system, PTs get paid incentives based on the level of quality care provided. It is important to note that as of right now, this isn't isolated to just PTs in private practice settings. This payment program has 4 components: quality, cost, advancing care information, and clinical practice improvement activities. Therapists must report on these components via electronic records or claims. For quality, under the MIPS program, the reporting threshold is 60%. So basically, this is saying you need to report on 60% of your eligible Medicare patients, but you are earning points based on your actual performance. So that means that Medicare is going to be looking at measures such as whether the therapist performed a pain assessment on an initial evaluation, whether the medication list is complete in the chart, or whether they did a fall screening on assessment or not. So they're actually really looking at whether you did what the measure is asking you to do. If you do not meet that reporting threshold, it is an automatic failure for that measure. For improvement activities, this is a new category in which you are attesting and acknowledging to Medicare that you are performing some improvement activities in your clinical practice. An example of this would be engaging patients and caregivers in developing a plan of care and prioritizing their goals for actions. The next measure is the Advancing Care Information, which just looks at the provider's use of certified health electronic record technology. And last, we have cost measures. These look at Medicare claims data, and at this point, Medicare is just starting to develop new cost measures, which look at very specific conditions such as stroke and total knee replacement. Clinicians that participate in this MIPS payment system will earn points in each of these performance categories to produce a total annual MIPS score on a scale from 0 to 100. After the data is collected, payment incentives or penalties will kick in 2 years later. Now switching over to APM, or Advanced Alternative Payment Models. This is a payment approach designed to provide high quality and cost-effective care for a specific episode, condition, or population. This program is required to have quality measures similar to MIPS. The alternative payment models are required to have and adopt some amount of electronic certified health record technology. Along with this, these models are required to have some financial risk. As of 2018, qualifying participants of APM have to receive at least 25% of Medicare reimbursement or see at least 20% of Medicare patients. If the qualifying participant meets these threshold levels, they will be exempt from MIPS reporting and will be eligible to receive a bonus payment of 5% of the previous year's Medicare Part B payments.
In outcome measures for best practice, physical therapists and physical therapist assistants should be utilizing evidence-based practice. They should be choosing treatment that is medically necessary while also acting in the patient's best interest. When the treatment is in the patient's best interest, it also has to be proven to be effective in treating the underlying causes of the patient's ailments. Physical therapists and physical therapist assistants get assessed on performance evaluation. These assessments are aligned with program goals. They complete the program goals with patients while utilizing best practice methods, and they also utilize quantifiable data to confirm if the goals are being met.
In summary, value-based care is a payment system devised to provide high-quality care while keeping costs down. And the new coding reform changes the way in which therapists and assistants interact with patients and how patients are billed for the rehabilitation services.